to start with, we'd like to have a look on the hallmarks of cancer, and those are characteristics that represents somewhat points of strength and aggressiveness of cancer. They're all driven by genetic events, and they manifest through proteins. And to look into how this works, it starts with the growth factor, like epidermal growth factor, platelet-derived growth factor, then stimulation of a growth factor receptor to form a complex that's able to cause signaling. And simply that's a message to the DNA to start the actions. By actions, we mean the ability to move, to metastasize, to generate their own blood vessels called angiogenesis, and to sustain the proliferation. And this, as we have mentioned, is driven by genes and executed by the products of those genes. And one example of those is the HER2 gene. So HER2 is the gene that manifests into an overexpression of the already existent epidermal growth factor receptor 2. And by this overexpression, it was noted since more than 30 years that it has some actions on the normal cells and the cancer cells. But it didn't implement into change of the treatment except after very well classification of this disease. So by HER2 overexpressing or HER2 positive disease, we mean that the HER2 3+ by immunohistochemistry and HER2 2+ that have CISH or FISH positivity, and that's simply more of a copy numbers of the HER2 gene than the chromosome 17 with a specific ratio. We'll not go through the details of testing, but you should refer to the recent CAP ASCO guidelines. And what do we know about those HER2 positive tumors? These are carry poorer prognosis compared to the HER2 negative tumors, more risk of relapsing in the lung, liver, and brain, and poorer response to endocrine therapy. And despite having some initial good response to chemotherapy, specifically anthracycline taxanes, however, shorter progression-free survival or disease-free survival if presented in the early stage. Those, of course, compared to the HER2 negative breast cancer. Till then, that was the problem. And with the start of this molecule, the trastuzumab, we have found some solution. So trastuzumab is a monoclonal antibody containing a murine part and a human part that was first tested in the metastatic HER2 positive disease and have succeeded to improve disease-free survival, progression-free survival, and overall survival. And that was around 20 years ago. Since then, application of the anti-HER2 therapies into the early disease have aimed to increase the overall survival and the cure rate of our patients. So before that, how did we treat non-metastatic HER2 positive disease? Simply by the same treatment that was discovered in ancient ages, where they were treated by upfront surgery and follow-up. But since Dr. Halsted have established his radical mastectomy 100 years ago, we have not succeeded to cure or to solve the problem of frequent relapses by an aggressive disease. So HER2 positive disease is an example for that, where we could not solve the problem of high rate of relapse. So the simplest scheme of management for the past 100 years was, after we diagnose and stage our cancer into non-metastatic disease, either we have a very small cancer or a small cancer that could be resected, so go for upfront surgery and whatever adjuvant therapy we have. And if a big or unresectable cancer, we have to start neoadjuvant therapy followed by surgery. Again, that was the ancient scheme. So in the adjuvant therapy, adding anti-HER2 therapy or specifically trastuzumab did make a difference. So first started with the HERA study that randomized patients to either observation or trastuzumab. And we'll focus on the 1 year of adjuvant trastuzumab here. So those patients have finished the adjuvant chemotherapy and added trastuzumab into that adjuvant chemotherapy. And as you might all know, adjuvant trastuzumab for 1 year did improve the disease-free survival and overall survival compared to no trastuzumab. However, it was shown since the first studies that addition of trastuzumab increases the cardiac side effects, congestive heart failure, symptomatic or asymptomatic decline in the left ventricular ejection fraction. So, as a result, improving overall disease-free survival and overall survival, in addition to a minor increase in the cardiac events. So, can we modify this regimen, or is this the only way to go? Well, this study, also another famous study, have shown us that we might have another way around. And this is very similar to the HERA study in design, despite two main differences. The BCRG 006 did use trastuzumab concomitantly with chemotherapy, not after we finished the chemotherapy, and was using a third non-anthracycline arm, the lower arm, where we use the TCH regimen, or docetaxel, carboplatin, and trastuzumab. And similar to the HERA study, adding trastuzumab to adjuvant chemotherapy did improve the disease-free survival and overall survival, with two more important results. Again, confirmation that the concomitant regimen works just like the sequential regimen, or might be even better, and that the non-anthracycline arm looks similar to the classic chemo arm. So, if using trastuzumab, you might think of omitting anthracycline, especially if your patients are at higher cardiac risk. So, looking at the safety, well, as we expected, adding trastuzumab to anthracycline increased the rates of grade 3 or 4 congestive heart failure. But in the arm where we didn't use anthracycline, we added only trastuzumab, this congestive heart failure rate was low, comparable or even less than the anthracycline arm without trastuzumab. So this might be the perfect regimen for the cardiac patient. The final conclusions of all the studies that pool the meta-analysis of all the studies that tested for 1 year of adjuvant trastuzumab, that adding trastuzumab to adjuvant chemo cuts down around 40 to 50% of relapses and around 1/3 of cancer deaths. This is a major advance that was introduced by this molecule, and it looked like all our patients gained the similar benefit. So it doesn't differ that this patient is ER positive or ER negative, not positive or not negative. They all gained same benefit from adding trastuzumab. And finally, increased cardiotoxicity, mostly the chemo cardiotoxicity. So what's the problem with that? The problem is that we now know that breast cancer is not one disease. So, for example, if you give neoadjuvant chemotherapy to 100 patients with breast cancer, you would find some group of them in the upper panel having very minor response or very low rate of pathological complete remission. That's what we call luminal A. And you find another subgroup, which is the HER2 enriched, like our patients, having higher rate of pathological complete remission. So not all patients respond similarly to neoadjuvant chemotherapy. However, if you look at the same cohort, if you, for example, did surgery and followed the patients for years, you'd find patients who do very well following surgery, and surprisingly, those who did not do well on the neoadjuvant chemotherapy. And you would see some patients who do very bad on following surgery and relapse much more than their HER2 negative counterparts. And surprisingly, again, those who would have done well if started by the neoadjuvant and anti-HER2 therapy. So that at least could direct us to one of two directions. So less proliferative tumors can go for upfront surgery, and more proliferative tumors, or those who are likely to respond from the neoadjuvant therapy, would be directed more to the neoadjuvant therapy. So after surgery, we do 1 year of adjuvant trastuzumab, and we have something wrong with that. First, that we have around 20% of the patients relapsing despite whatever we do. We give full chemo and full and 1 year of 1 year of trastuzumab, and we have around 20% of the patient responding, and that's the clinical trial population. But if you look, for example, at the Egyptian data, you would find the high-risk groups much more than the BCRG 006. That's to say, we'd expect much more than the 20% to relapse. On the other hand, we have around 70% of the population that receive overtreatment, meaning that they wouldn't have relapsed anyway, even if not receiving trastuzumab, and even if some of them wouldn't have received chemotherapy. So let's focus on the red group where we need to escalate. Who do we escalate and how do we escalate? Let's start with the second question. How do we escalate? Can we have better strategies that could address the high rates of relapse in those patients? First, we have another molecule that's pertuzumab, antibody that blocks dimerization between generally HER2, HER3, but another as well. So dimerization of the receptors is one of the main upstream signaling that will lead into signaling into the DNA, and blocking both the HER2, HER3 dimerization by the combination of trastuzumab and pertuzumab have shown synergistic effect. And it had succeeded in the metastatic setting, and when you use that in the neoadjuvant setting, you would see on the left-hand side in the NeoSphere study, adding pertuzumab to trastuzumab have improved or have a trend towards improvement of the disease-free survival in patients receiving neoadjuvant therapy. On the right-hand side, the affinity results, specifically the node-positive population, where adding pertuzumab to a trastuzumab-based chemotherapy did improve the invasive disease-free survival. And this is a proof of concept that if you add this molecule, it might work better. And that's why the standard neoadjuvant regimen in most patients now is considered the dual blockade. So this was on the affinity, those who gained benefit was the node positive, and in the NeoSphere, mostly were node positive or larger tumors. So that made us use the dual blockade in those who would require neoadjuvant therapy, which will mostly be a node positive or large tumor. So this is a trifina study where we just tested which neoadjuvant regimen we'd use. So it just randomized patients, 225 patients with operable or locally advanced breast cancer into one of three arms. First, the FEC followed by trastuzumab, FEC combined with trastuzumab and pertuzumab, in addition to 3 more cycles of docetaxel, trastuzumab, and pertuzumab. So this arm added the dual blockade to all the cycles, including the anthracycline. The second used the classic FEC without anti-HER2, followed by docetaxel, trastuzumab, and pertuzumab. And the third arm was what we call the TCH regimen, the TCHP regimen, which is docetaxel, carboplatin, trastuzumab, and pertuzumab for 6 cycles. The primary endpoint was the PCR. And if you look at this comparison, this is the total PCR, or the nodal and the tumor PCR, where you find both the anthracycline containing and the non-anthracycline containing are the same. So this is another success for the TCHP regimen, which can be used as an alternative to the anthracycline taxane sequential regimen when treating in the neoadjuvant setting. And finally, can we do that safely? Are we sure of the long-term results? And here we will need to get back to the TRAIN2 study. It's a Dutch study that randomized patients into 9 cycles of chemotherapy, and it used non-classical paclitaxel regimen with day 1 and 8, but it's typically used around 18 doses of paclitaxel plus carboplatin plus pertuzumab and trastuzumab, compared to 3 cycles of anthracyclines, then 6 cycles of the TCHP. And the main question was anthracycline versus no anthracycline, and the primary endpoint was PCR. And as you see, you can see no difference between both arms in the PCR rate. In addition, you have, as expected, less cardiotoxicity in patients who used TCHP or did not add anthracycline, and you have also less febrile neutropenia in the non-anthracycline arm. On longer follow-up of those cohorts, you would see that there is no difference in the event-free survival between the anthracycline and non-anthracycline arm. So it's safe to go for TCHP as a neoadjuvant therapy followed by surgery without adding anthracycline. Of note that patients who following surgery, patient completed 1 year of anti-HER2 with trastuzumab alone and not the dual blockade. So that makes us think of another scheme that very small cancers, you could go for upfront surgery followed by adjuvant therapy, just like the HERA and the BCRG06. And if you have, again, not large, but anything but a very small cancer, you should go for neoadjuvant therapy followed by surgery. And why is that? Because we have what we call a response-adjusted adjuvant therapy. If you went for neoadjuvant therapy and your patient failed to achieve PCR, and those could be around 30 to 40% of the population, if you fail to achieve PCR, then according to the KASSEM study, patients with non-PCR were randomized to trastuzumab versus TDM1, the antibody drug conjugate, and again, those with residual disease have a significant 50% reduction of the risk of invasive relapse compared to those who were kept on trastuzumab. That big difference have led to an approval and have led to also the use of the TDM1 in the Egyptian protocol for the non-PCR. Again, this have led to into adopting neoadjuvant strategy in almost all patients except those with very small cancers. And again, we look into the sizes and how do we select patients for the de-escalation using upfront surgery. So for more patients where following surgery and receiving adjuvant HER2, could we extend the adjuvant anti-HER2 therapy just like we do somewhere in the ER positive tumors? Well, one study have looked into that. Of course, the extension of trastuzumab have failed into the HERA study, so 2 years are not better than 1 year. But if you used another agent, this is tyrosine kinase inhibitor, neratinib, approved for the metastatic setting, and now for the adjuvant setting by the extended adjuvant strategy. So it blocks, it's a pan-HER2, it has more potency than the lapatinib, but again, much more toxicity, specifically diarrhea. So this molecule, which is a tyrosine kinase inhibitor, if you use it following 1 year of adjuvant trastuzumab, that's to say extension of the adjuvant duration compared to placebo, it did improve invasive disease-free survival by around 27%. However, it's not adopted in most countries due to the side effects and due to the availability of different strategies, not different agents. So the more difficult question than the how to escalate, where we will use the neoadjuvant strategy, but for who? That's the most important question. Well, we can just extrapolate from studies that put patients into the neoadjuvant regimens. So relatively larger tumors, relatively node positive, and might be ER negative. We're not sure which exactly, but if we decide to escalate, we should better focus on who not to escalate or who to de-escalate the treatment strategy. And this is the green group here. So we will look into patients where we can de-escalate or decrease the treatment, and the rest we will keep on the escalation strategy. So de-escalation can have two arms, whether to decrease the chemotherapy used or to decrease the trastuzumab used. First, we have a very interesting study that was done by Sarah Tolani and colleagues, where they did use a de-escalated chemotherapy regimen of weekly paclitaxel of 12 weeks only. That's a single-arm study, and it did include tumors less than 3 centimeters in dimension and node negative. So they are T1, small T2, and node negative patients to receive only 12 weeks of paclitaxel plus 1 year of trastuzumab. And please note that the majority have a T1 disease. And it had a very encouraging results where 3-year invasive disease-free survival rates was 98.5%, and at longer follow-up, again, 93% disease-free at 7 years. And this is very encouraging results, actually very similar to what you achieve in patients who did achieve PCR after neoadjuvant therapy. So now we can de-escalate chemotherapy for patients who would not tolerate or will not prefer to receive chemotherapy. 12 weeks of paclitaxel is really easy to administer. And again, of course, with no anthracycline, you will have much less congestive heart failure. That's mostly reversible. So can we decrease the trastuzumab? We might need to decrease trastuzumab for cost reasons and for also some cardiac safety reasons. So as you know, there are 5 studies that have looked into the de-escalation, and there's a meta-analysis to show, but the real question is, who can we decrease the duration of the trastuzumab to? And if we looked into the FAIR study, it did not show, it did not prove non-inferiority between 6 months and 12 months of trastuzumab. Yet we can look into the subgroups of them. So at least tumors that were larger than 2 centimeters, despite the majority had a similar hazard ratio, but in patients with larger tumors, it looked like they had 40% more risk of relapse compared to the 12 months. So if you decrease the duration of trastuzumab in larger tumors, so you can debate on the size, 2 centimeters or more, but if you decrease the duration, you would have much more relapses. And also, if you looked at the combined N and T stage in the short hair study, in the low-risk population where the T1 and 0, similar to the Tolaney study group, you can see a difference on the right-hand side, the 5-year disease-free survival, 91% versus 92%, comparing short and long course. And in the intermediate risk population, again, not much difference. But if you look at the node positive, heavy node positive tumors, you would see that there is a big difference between shorter duration of trastuzumab and longer duration. So do not de-escalate trastuzumab duration for patients with large tumors, more than 2 or 3 centimeters, and those with heavy nodal infiltration. So my conclusions, you would have to classify your patients with early or non-metastatic HER2 positive disease into at least one of 3 categories. First, very small tumors and node negative. I would restrict those to T1 and 0. You should go here for an upfront surgery. It's an opportunity to de-escalate the chemotherapy plus or minus de-escalation of trastuzumab. So you could go for a paclitaxel 12 weeks plus trastuzumab for 6 to 12 months. And this is a very well-tolerated regimen. The second option that you would have a patient with an intermediate risk disease, a T1 and 1 or a T2 and 0 and 1 disease, you would have to go for a neoadjuvant strategy for that. You would prefer TCHP to decrease the risk of febrile neutropenia or to decrease the risk of cardiotoxicity. However, for financial reasons, you might go for the sequential anthracycline taxanes, and both are okay. Then followed by surgery. If you went for surgery, you would have either a PCR and you would have the opportunity to go for a trastuzumab for a completion of 1 year, or a dual blockade for the completion of 1 year, or non-PCR, you would have to go for a TDM1. In a larger tumor, you will also have to go for a neoadjuvant therapy, TCHP or anthracycline, and followed by taxane plus dual blockade. Some centers prefer to use to add anthracycline in those with very large tumor or inflammatory breast cancer, followed by surgery, of course. And again, if PCR, then go for continue 1 year of trastuzumab. If non-PCR, you have to go for a TDM1 to decrease the risk of high relapse with those high-risk patients. And thank you very much.